Tapering off prednisone. That is what we're going to focus on today because people really struggle with this medication. It's an amazing medication. It saved my life and so many other people's, but getting off of it is an entirely different challenge. That is what we're going to focus on today is how to get off prednisone safely. How do you get your adrenal glands to recover? How do you taper prednisone? And I've gotten so many questions about this throughout the years. And I've created a video here and a video there to answer these questions. And the only way I could answer the question was by finding one person who wrote a scientific article, or maybe a group of people who wrote a scientific article. But there was no guideline, there was no clear answer of exactly what the truth was, what the complete accurate truth was for this complicated question of how to taper prednisone and how do you recover your adrenal glands while stopping it. And I've had to kind of fill in gaps here and there. And it's been really hard answering questions like this because it was basically like, this is what I think, but the science only says this much. I don't know. So I'm so excited because today I have an actual guideline written by world-renowned experts about tapering off prednisone safely, about adrenal recovery, the whole shebang. And so I'm going to go through many of the questions that I've been getting about this topic. And so if you have more questions about this topic, please drop them in the chat. I would love to see them, uh, hear what you have to say about this. Ooh, okay. Here's our first question, and I'm just going to show them, but I promise I will answer them all by the end. But here's one of them. How long is too long for symptoms of prednisone withdrawal? Great question. We'll definitely be getting to that type of question. What other questions do people have? Drop them below and I can answer them for you. So, what is this guideline? Well, I'm going to show you my printed off version. It's the European Society of Endocrinology and the Endocrine Society. These two groups, I think it's Americans and Europeans, all of these doctors, specialists in the endocrine system. That's the hormones in your body. That's what prednisone is messing up. How to recover, they outline it here. And it's an amazing guideline. But I had to study it. I had to really think, and I speak medicalese. I feel like going to pharmacy school and getting my doctorate of pharmacy was essentially learning how to speak medicalese. So if you don't already speak medicalese, what I'm going to do is take those questions you have, drop them in the chat if you have more about tapering, withdrawal, adrenal recovery, that type of thing. And I'm going to translate this fantastic information into something that you can actually understand and implement in your life to know what is actually going on when it comes to prednisone, adrenal recovery, tapering, withdrawal, all the things. So the first thing I want to talk about is why do we even need to taper prednisone? The why. I want to answer the why before later we get to the how we taper prednisone and when do things change? When does the recovery? So we're going to start with why, and we'll start with, and then we probably will get to who, and then we'll go to when, and then how. So why do we taper? Well, prednisone, this miracle medication that we have that saved my life and many other people, it is a prescription version, a chemical that is mimicking one already in your body. The one already in your body is called cortisol. And cortisol is in every animal. It is the hormone that keeps us safe. It allows the gazelle to run away from the lion. Allows the human to avoid the bear or the gorilla from killing us, right? Like it keeps us safe. It allows us to avoid wars. It allows us to get away from famine, to find food. It keeps our species safe. Mother Nature designed it to help you deal with those stressful situations. So, Mother Nature didn't want you to be always in that reactive, I'm running away from the tiger mode. She wants us to be safe most of the time. And so she designed this intricate system that allows you to have high moments of cortisol naturally. And then it naturally brings itself back into equilibrium, to homeostasis, into balance. So you don't have the awful side effects of being revved up all the time. Essentially, if this is a car analogy, having the gas on all the time because you're running away, like you're trying to get away. You're in the getaway car and never having the brakes or having them both going. So now you're getting away fast and you're burning your tires, right? Like we don't want either of those things. Your mother nature wants you to bring it down, to be in rest or digest safety mode most of the time. The cortisol is to be temporary, is to be at low doses most of the time. And so she brings it down by having these signals in our body communicate to each other. So there's two places in your brain and one place right above your kidney that have an intricate dance. They send messengers to each other, the hypothalamus, the pituitary, and the adrenal gland. And those messengers, if one of them is too high, the others will stop being sent. So, for example, when you take prednisone and you're replacing cortisol, you're sending that signal way up. So these other two signals are like, oh, it's way too high. We just won't send the signal back down there to make more more cortisol. We'll just turn off so that it slowly gets back into normal balance. The problem is you're never getting back into normal balance on your own because you're taking prednisone. You're replacing that cortisol. You're artificially hijacking the amount of cortisol that's floating around in your blood with this medication, which has a fantastic purpose. For me, it stopped my autoimmune disease from causing me to be bleeding to death. For other people, it allows you to not have rheumatoid arthritis pain and to actually open the jar. For people with asthma, it allows you to breathe. And for many other autoimmune and inflammatory conditions, prednisone is a miracle. And we're grateful that it's there. But it's causing this hijack. It's causing this super high amount in your body. So the idea is we need to have that system, and I'm from now on going to call it HPA, hypothalamic pituitary adrenal, HPA axis. It needs a chance to recover. It needs a chance to turn back on. Once those messages are slowing down from the cortisol side, then slowly the brain side can start turning back on and send messages back to your adrenal cortex and start making your own cortisol again. But that whole ability to recover takes time. And because cortisol itself affects up to 2/3 of your genes, everyone's recovery is different. Everyone's timing of recovery is different. Everyone's experience of the recovery is different because it's completely genetic. 2/3 of it. It's affecting 2/3 of your genes. So in that way, that is the why we need to taper, because this takes time to recover. For some people, it can recover in a few days. For other people, it takes months, if not years, of gentle, slow tapering for this whole system to recover. And so now I'm going to talk about who. Actually, no, I'm going to go with more definitions because we need to understand what we're looking out for. Like, what is the problem? So there's lots of side effects of prednisone, and I've gone through those in depth in other videos. The specific problem we are looking to avoid, the point of the whole video today, is we want to avoid going into one of two things: withdrawal syndrome or adrenal insufficiency. So withdrawal syndrome is basically similar to the principle to if somebody is an alcoholic and they're used to getting a drink every day and suddenly they go cold turkey, their body goes into withdrawals. And if someone's a severe alcoholic, they actually need to be hospitalized to get through that chemical withdrawal. It is the amount of chemical alcohol that their body has become used to, they've become dependent on, is now causing their body to go into an awful, possibly even life-threatening withdrawal. Same thing with pain medications. If someone is used to being on a certain level of opioids, heroin, morphine, whatever, fentanyl, and they suddenly go cold turkey, they will start shaking, their eyes will dilate weird, and like all sorts of stuff. It's a chemical dependence, and not having enough of it causes a reaction in your body that feels awful. So for prednisone, let's talk about what that thing is called. So in this guideline, I've colored it, I've highlighted it. I love it. It is so good. But I wanted to tell you what their definition of withdrawal syndrome is. They say that glucocorticoid, and let me define that first. Glucocorticoid means gluco means sugar, corticoid means that part of your adrenal gland. So basically, prednisone, when you hear that word, glucocorticoid, you can think prednisone. Withdrawal, and I've talked about that, syndrome. So this is a bunch of symptoms experienced when lowering glucocorticoid dose within the supraphysiologic glucocorticoid dose range. Now, that's a really big term. Let me define that. They say that your body makes somewhere in the equivalent of 4 to 7 milligrams of prednisone. Somewhere around there is the equivalent of cortisol. Prednisone, 4 to 6 milligrams to cortisol that your body normally makes. When you don't take prednisone, that's how much cortisol you have floating around. That's how much your body makes in that adrenal cortex. And so that dose, prednisone 4 to 6 milligrams, is what they call the physiologic dose. That's how much your body's used to on a regular basis in a normal, healthy environment. So anything above prednisone 6 milligrams is what they're calling supraphysiologic, above this physiologic dose. Ooh, here we have more questions coming. I love it. Keep dropping questions about tapering and withdrawal and everything here, and I'm going to answer them. So a supraphysiologic dose. So if you're taking something above that and you're dropping rapidly and you're experiencing symptoms, that's what they've said so far about the definition of glucocorticoid withdrawal syndrome, that are not due to the underlying disease for which the glucocorticoids were initially prescribed for. So if you're dropping dose, you're above 6 milligrams, and it's not your disease coming back. So in my situation, for my disease, it would be that I'm suddenly bleeding. I'm suddenly having weird rashes. For somebody who has rheumatoid arthritis, it's that you're getting joint pain. For someone with polymyalgia rheumatica, you're getting shoulder joint girdle pain. You're getting maybe hip pain. Just the symptoms you originally had before you took prednisone. If they're coming back, that's not withdrawal. Okay. And then not due to untreated adrenal insufficiency, as the total glucocorticoid daily dose is still supraphysiologic. So essentially, withdrawal is when you drop the dose and it's causing symptoms, and it's not your disease, and it's not adrenal insufficiency. That's what glucocorticoid withdrawal is. I'm just going to call it withdrawal from now on because it's really hard to say that first word fast. Now, let's talk about, hi, Bonnie. Bonnie has PMR. Now, let's talk about what is adrenal insufficiency. So, their definition is, that's funny. They don't actually define it. I thought they did. Okay. Well, basically, adrenal insufficiency is when the amount of cortisol in your body isn't enough for your body to function properly. And that can be caused by prednisone. That can be caused by some part of your HPA axis being destroyed, whether you have a tumor on your pituitary gland, or for some reason some damage was caused to your adrenal gland above your kidney. for whatever reason, if there's a physical damage or an autoimmune destruction, that there's something wrong with it, some combination of that going wrong can happen. So it can be a physical thing, it can be a chemical thing, or it can be a drug thing like prednisone. Any of those can cause adrenal insufficiency when you don't have enough cortisol in your body. All right. So now that we have these definitions, who was the next question I was going to answer? Who is at risk for that problem, that adrenal insufficiency caused by prednisone, not caused by those other reasons? And they have a really cool chart that I'm getting to. Here we go. Okay. Here's the chart. I'm going to go through it. So who is at risk for adrenal insufficiency? There are 6 factors to consider. And every person, their genes obviously have an impact here. I mentioned that cortisol affects up to 2/3 of genes. So the first thing to consider is your genes. Without that, these are the things that they recommend, that the factors the endocrine society considers in who's at most risk. They have those at the lowest risk and moderate risk and then high risk. So where are you with the following 6 factors on this range? So pay attention to what the 6 factors are so you can decide how likely you are to get adrenal insufficiency when taking prednisone if you don't taper properly, so that you can keep listening to find out how to taper properly at the end. Okay. So what matters first? The first factor is glucocorticoid potency. So while I'm the prednisone pharmacist, there are a lot of other medications that are similar to it that are mimicking cortisol as well. And so the lowest potent glucocorticoids include hydrocortisone, cortisone acetate, and deflazacort. And then the middle range, risky medications include prednisone, prednisolone, which they basically say are exactly the same in this guideline, methylprednisolone, triamcinolone. Those are the moderate. And then the high risk steroids, yikes, these are more likely to cause adrenal insufficiency, are dexamethasone, betamethasone, and fluticasone. Okay. So not all of those are oral. You'll notice you can't actually swallow all of those as a pill. So that's where we come to our next thing is administration route. So essentially that's how is that steroid getting into your body? So there's the least risky, which include nasal spray, a topical cream, or an eye drop. Those are the least risky to cause adrenal insufficiency. And then the moderate risk is an inhaler, inhaled corticosteroids. And then highest risk are what they call systemic, or something that's going to your entire system, your entire body, like a pill, an oral pill like prednisone, right? Going into your muscles, an injection into your shoulder or your hip, and then intravenous, being injected through a vein. And that one is usually only at the hospital. And then there's intra-articular, that's into a joint. So like into the shoulder itself or into the hip itself, not into the muscle, into the joint. Ooh, okay. Here's the problem we're solving today. All right. I'm going to show a few of these questions that we will be getting to. This robot says, every time I go off, my body reacts and I get into pain and beat flares and I got to go back on and taper again and again. I want off. Here's another one. Bonnie says, I'm trying to taper. My doc wants me to stay on 15 milligrams for another month. My question, does my body benefit from going to 10 milligrams for 3 days or just stick with 15? So we're going to get to tapering and withdrawal and all of these questions by the end of this live stream. So let's continue with the 6 risk factors for who's most likely to have adrenal insufficiency and withdrawal misery. So the last route of administration is if you are combining multiple routes. So if you're on an eye drop, an inhaler, and you're taking a pill, you're more likely to get adrenal insufficiency as opposed to someone who's just on an eye drop, right? Okay. The third factor is the dose. So low doses, low risk. Medium doses, medium risk. High doses, high risk. What I love is they didn't actually define what these are. But I would say, my guess is that 7 milligrams and below is low dose, 7 to like 19 milligrams is medium dose, and then 20 milligrams of prednisone and above is high dose. That would be how I would define it, but they didn't actually define it. So my guess is as good as anyone else. Number 4 factor to consider, risk factor, is duration of use. If you take prednisone or another steroid for only 3 to 4 weeks total, I'm not saying every few months, I'm saying period, for 3 to 4 weeks, and that's it, that's low risk, which is a much bigger range than I thought. All the research I'd read up until this point had a cutoff of like 14 days, max of 21 days, but they're pushing it out to 28 days where it's low risk. So that's cool. That's more liberal and, reckless than I've ever seen in any science. So the next moderate risk is that 21 to 28 days, 3 to 4 weeks, to up to 3 months. And then if you take prednisone or another steroid for longer than 3 months, you're at higher risk for adrenal insufficiency. All right, number 5 factor to consider of who's going to get adrenal insufficiency is body mass index. So your body itself. Lower weight people are less likely to get adrenal insufficiency. Overweight people are medium risk, and then obese people are most likely to get adrenal insufficiency. And then finally, risk factor number 6 is age. So younger adults are low risk, older adults are higher risk. So, you can now put yourself on the spectrum of where your risk is for adrenal insufficiency. You may already know how hard it is for you to taper. So tapering itself is a beast, but could that tapering lead to an even worse complication of adrenal insufficiency? And if so, those are the 6 factors to consider. All right. Now I wanted to talk about what they said we need to be covering. They said that doctors and pharmacists should be covering these topics. So that's what I wanted to cover with you today. These are the topics they specifically said right here. They said doctors, clinicians, pharmacists need to be educating the following things. Your risk for developing Cushing syndrome. What's that? That's like moon face, weight gain, like in your belly, in your face, muscle loss, bone demineralization is the term they use, bone loss, osteoporosis, heart disease, high blood pressure, high blood glucose. They want people being educated about that. Second, your risk for developing adrenal insufficiency. That's what I'm mostly covering today. That's my focus of today. The third is education on stress dosing techniques. I made a video about that about a month ago. You should check it out, but not this second. You should keep watching. Number 4, education on injectable emergency glucocorticoid administration. So if you do have adrenal insufficiency, you do need to stress dose according to your doctor. How do you do it? That is what people need to be educated on. And then number 5, glucocorticoid withdrawal syndrome. So I'm tackling number 2 and number 5 right now. What are these things that you need to be aware of? And when should we do this? That people who are on long-term doses higher than 7 milligrams need to be educated on the withdrawals and adrenal insufficiency. It's really important because I didn't learn about this in pharmacy school. I don't think most doctors even learn about this in medical school. I went to Harvard for a continuing education event at the beginning of the year, and I tried to talk to the doctors there about this exact topic, and they were like, What are you talking about? Like, they'd never heard of withdrawal syndrome. This is like well respected Oxford. Like, this is real. This isn't made up. And these Harvard professors of rheumatology had no idea. So, like, it's not just me. It's hard to get the good information. So now I want to talk about a really cool term that I'd never heard before. And it's going to answer a lot of the questions that you have about. I've already talked about physiologic dose is somewhere between 4 to 6 milligrams of prednisone. That's what your body would be making in cortisol. And that any dose above that is called supraphysiologic dose. And so tapering above that is a different strategy than tapering when you get there and below. That was to see them put that in black and white, evidence-based text. Tapering from way high is a lot easier than tapering from low. So I think I had a question about that. Let's see. But basically, yeah, I had it. It was on Facebook. There was a really good question. She said, I am in the middle of a fast taper from 40 to 0. I'm at 20 right now. After 7 days, 15. Another 7 days, 10, etc. I've heard it's the lower doses that are the most challenging. My rheumatologist told me it won't be a good time, but so far, not terrible. Wondering if the hard part is just up ahead. I love the way she phrased that because it's so true that tapering, I'm going to read it and then translate it to you. This is what they said. Taper of glucocorticoid therapy dose, initially guided by the management of the underlying disease. They are defining that as a therapeutic taper. And later by the management of glucocorticoid withdrawal and adrenal insufficiency. And they call that the endocrine taper. So now I finally have a way to describe. I used to go like this in my videos. You need to balance whether your disease is under control with being in withdrawal symptoms. And they say that that first taper is just about your disease itself, making sure that your disease is under control, that we never taper if your disease is out of control unless your doctor has another plan, starting another medication, or your side effects are too horrific and you have to taper. But if you're taking prednisone for a purpose and there's no alternative that you're turning to, there's no point in tapering prednisone yet if your disease isn't under control. If you have giant cell arteritis and you're going to lose your vision possibly, you stay at 40 to 60 milligrams until that inflammation is under control, or you could lose your vision, right? For me, with my autoimmune blood disorder, ITP, there's no point in tapering if I'm actively bleeding, if I'm having rashes of blood under my skin. There's no point in tapering. It's not safe. So step one is the therapeutic taper, that you first get to the effective dose that will control your disease and make sure it is actually under control before you move on to now what they call step two, the endocrine taper. That at this point, we're talking about hormones. We're talking about the recovery of your HPA axis. I'm so glad they finally gave a terminology for this because I've always just kind of been like, it's like this, you got to keep them in balance. And now I have a definition. We need to focus on a therapeutic taper, get your disease under control. Then we can talk about this next step, this endocrine taper, the whole complications of how to do that. All right. I'm going to show a few more questions so you people can see who else is here. We have Polly saying she has 6 out of 6 of those risk factors for adrenal insufficiency. Multiple tapers, finally off decreasing prednisone a half a milligram a month since getting below 10 milligrams. That sounds exactly right. 1 month off, still having extreme fatigue, weakness, nausea, irritability. Woo, thanks for like transitioning to my next thing. I'm going to share a few more, but like remember what she just said. Peter says, "Hi, I have PMR, so I've been told by a doctor I've never had any relief from prednisone. As I have said, I'm on 5.5 milligrams for 4 days now. 90% of my pain is in my buttocks. When I sit, I have less pain. When I lay flat on my back, no pain at night. When I sleep, 5 milligrams low dose. I've been on prednisone for 2.5 years. Doctor wants me off as soon as possible. I've been losing weight." So remember his symptoms too, because we're going to talk about those factors too. Patrick says, "How about 79 years old, 3 a day for 20 years for RA? Are my adrenals toast?" Let's find out. Fred says, "I was on massive doses, now on downhill side at 40 milligrams, taken every 14 days. Spoke with my neurology doctor about the side effects and other problems related to withdrawal, only to be told they don't monitor." Okay, I'm going to answer this one first about they don't monitor, because a lot of doctors like neurologists, rheumatologists, these other specialists who are prescribing prednisone, they want to just say, "Hey, just go see an endocrinologist and they'll figure out your taper." And I'm going to find this quote because I loved it. They recommend, this is their first recommendation on the whole document. "We recommend that, in general, patients on or tapering off glucocorticoids for non-endocrine conditions." They're saying you're taking it for anything but adrenal insufficiency, okay? "Do not need to be evaluated by an endocrinology specialist." So like actually your neurologist or whoever prescribed your prednisone, it's their job to monitor you. That's their job. If not, they need to connect you with a primary care doctor who can monitor you. But like endocrinology is saying this is the prescriber's problem to deal with, not our problem. We're too busy. We have enough people to deal with. There aren't enough endocrinologists in the world to deal with all the tapers in the world. So yeah, that was, I enjoyed that one. Okay. So now let's talk about who needs to taper and who does not need to taper. And this definition, again, was surprising to me because every resource I've ever read, and I've read hundreds of scientific articles about prednisone, tapering, glucocorticoids, withdrawals, everything. And it's always been 2 weeks, max of 3 weeks of when you don't need to taper. That if you take prednisone for 10 days, okay, you don't have to taper. 14 days, you probably don't need to taper. But 21 days, oh yeah, like anything beyond 21 days, you have to taper. That's what every article I've ever read said, like nothing beyond 21 days. And this one's saying 3 to 4 weeks. So that was pretty cool to finally have a definitive source say beyond 4 weeks, yes, taper, but less than 3 to 4 weeks, almost up to a month, you don't need to taper. So a doctor can prescribe prednisone 20 milligrams every day for 28 days, according to this, and not taper. And I'm like, wow, that that is pretty bold. I had never heard that. And so that they call that a short-term glucocorticoid therapy. Any therapy of less than 3 to 4 weeks duration. So then long-term is greater than 3 to 4 weeks with a dose greater than the physiologic daily dose equivalent. So if you're taking more than 4 to 6 milligrams of prednisone for longer than 3 to 4 weeks, you are taking long-term prednisone, which was another surprise that their long-term is 3 to 4 weeks, like beyond 3 to 4 weeks. That really was surprising because other definitions were like 3 months and beyond is long-term. But they're saying that that is long-term therapy. And if you want to know if you're on a different medication that's similar to prednisone, that is the equivalent of 15 to 25 milligrams of hydrocortisone, 4 to 6 milligrams of prednisolone, 3 to 5 milligrams of methylprednisone. They spelled it wrong. That's methylprednisolone. And 0.25 to zero point 0.5 milligrams of dexamethasone. So we now have some answers of who actually needs to taper and who doesn't need to taper. And that is a huge relief to me to have it spelled out in black and white like that, knowing, okay, your doctor prescribed it, just follow your doctor's prescription and that should be fine. There are going to be a few people who still are going through withdrawals even after that time. But for, 90% or more people, then it's fine. It's fine to be on prednisone for that amount of time and not taper. As long as you're only doing it that one time. If you're doing that every couple months, then that doesn't count. That's like per year. Okay. Now we've talked about who needs to taper. We've talked about at what point you need to taper. And we talked about what they want us to educate you about. So there's another topic I want to discuss. Okay, so this one is really fascinating to me to finally have an answer to this question. That there's a term, prednisone withdrawal or glucocorticoid withdrawal. And then there's a term, adrenal insufficiency. What's the difference? How do I tell the difference? And then the question people with PMR especially get, like I had Bonnie say I have PMR. PMR patients are on prednisone longer than basically anyone else. So you win if you have PMR. We have Peter with PMR as well. So basically, for people who are on prednisone that long, you need a good strategy to taper. And for PMR, it's really, really hard to tell. Is it withdrawal? Is it adrenal insufficiency? Or is it your disease flaring? Okay. It can't, like, by definition, if it's your disease flaring, it's not withdrawal or taper or adrenal insufficiency, right? So first of all, we got to see which of these is it? And they gave us a bunch of factors to consider and a bunch of ways to test to find out because I knew of no way to distinguish between the three of these before. And now we have some definitions, some ways to distinguish. So, glucocorticoid withdrawal, adrenal insufficiency, disease flare. I'm going to put them here with my hands so you can see them. All right. So, if it is your disease flaring, then it depends on your condition. If it's your asthma flaring, you're not breathing well. If it's your rheumatoid arthritis, your wrist and your joints, your little joints are in pain, they're swelling, they're red. If it's your PMR, you're suddenly having that shoulder pain, right? Or your buttock pain, the hips, the shoulders, those bigger joints. Um, and every disease is different. And so you really have to know your disease, the symptoms, because it might be a little different than before. But for people with PMR, it's shoulder pain. But for glucocorticoid withdrawal syndrome, actually, we'll do adrenal insufficiency first. The symptoms you can feel and describe to your doctor include, see if you can distinguish these from anything else you've ever heard of. General malaise. That means you just feel yucky. Fatigue. You're really tired all the time. Nausea. Muscle and joint pain. Okay, so that sounds like the flu, right? Aside from not being a fever, that sounds like the flu. So what about withdrawal? Is there a difference? Okay, so symptom number 1, general malaise. You feel yucky. Fatigue. You're really tired. Nausea. Muscle and joint pain. Oh, wait. They're the exact same first 5 symptoms for both adrenal insufficiency and glucocorticoid withdrawal syndrome. But they keep going with glucocorticoid withdrawal. They also include sleep disturbances and mood changes. So if it's affecting your sleep or your mood, it's less likely to be adrenal insufficiency and it's more likely to be withdrawal syndrome. Interesting. I'd never heard that distinction before. Fascinating. Let's find out more. So, the signs, if it is your disease coming back, the dose is basically not high enough to keep your disease under control. In my situation, that was the rash coming back. It was bleeding showing up on under my skin. For people with PMR, it's the pain coming back. For people with asthma, I've already said breathing difficulties, right? For adrenal insufficiency, weight loss. Now that's tricky because prednisone causes weight gain. And so often just coming down on doses, you're going to lose weight anyway because you're losing that prednisone weight. So that's a tricky, like kind of non-specific thing. And like if you have the flu, you often lose weight because you're like throwing up or you're just not hungry, right? So that's a tricky non-specific thing. But then these two next things are a little bit more specific for adrenal insufficiency: low blood pressure or hypotension. That isn't common with glucocorticoid withdrawal or your disease coming back. And related to that is called orthostasis, or basically getting dizzy when going from lying to standing or from sitting to standing. That just like, whoa, and you like kind of black out. That's more likely to be adrenal insufficiency. Okay. Then another sign of, so we talked about those are the signs that's adrenal insufficiency. Now, what are the signs of glucocorticoid withdrawal syndrome? When would a doctor be most concerned? Like, what are they seeing in the clinic? What is visible to them? Cushingoid features. So that's a really nice way of saying moon face, a buffalo hump, belly weight gain, especially earlier in the glucocorticoid taper. So basically, if you are dealing with those complications, the muscle loss, the fat redistribution, the high blood pressure, those are more likely to be causing withdrawal than adrenal insufficiency. I'd never heard that before, that association of Cushing's with withdrawal as opposed to leading to adrenal insufficiency. Fascinating to have that distinction. Okay. Oh no. I did not necessarily want this response, but I'm just thrilled to finally have these answers myself. I hope this is helpful as well, not just concerning. Um okay, so that was the signs. Now, what is the timing of the symptoms? All right? Like at what point in your journey taking prednisone are these appearing? So, for the disease specific, it can be at any point during the glucocorticoid taper if the underlying condition is suboptimally controlled with a non glucocorticoid agent. In my situation, to translate that, it is that when I was on a dose high enough, prednisone controlled my body from attacking itself and making me bleed. When I would try to taper down, the bleeding would come back unless I got on another medication. Thankfully, my doctor got me on another medication called Rituxan, and it was able to control my disease. And so, if your disease is not being controlled by something else and the disease is flaring, then yeah, okay, it's your disease causing these symptoms, right? Okay, what about, we'll skip to withdrawal. The timing of the signs and of symptoms and signs occurrence at any point during a glucocorticoid taper, and usually when the dose is decreased to less than 15 milligrams a day. So, to answer several people's questions is when is this going to happen? Usually at 20 milligrams, almost no one's having withdrawal pain. It's when you get 15 milligrams and below that you start possibly feeling withdrawal. It's less likely if you're dropping from 60 to 40 to 20, even those are huge drops. It's less likely to be causing withdrawal. Okay. And then they say it's a higher risk with long-term supraphysiologic glucocorticoid therapy. Basically, that's saying you're at a higher risk of withdrawal if you've been on a long time of really high doses. Okay. So now, when is it adrenal insufficiency? What is the timing? Only when not treated with optimal glucocorticoid therapy. Hmm. Subphysiologic glucocorticoid dose, increased glucocorticoid requirements due to sickness. They're saying it can only be glucocorticoid withdrawal if you're not getting enough prednisone or other steroid in your body to deal with your actual needs of stress, of maintaining your life, your health. If you're sick, you're vomiting, you're not you're not able to actually absorb the pills, then it might be adrenal insufficiency because you're getting less than optimal amount of medication into your body. Okay. Now, what about biochemistry? What blood tests can they test for? For your disease, it's a biomarker of your disease itself. For people with PMR, it's your ESR and CRP, those inflammatory markers. For asthma, it's like your breathing. Oh, shoot, what's the term? There's a term for it. For me, it was my platelet level, the blood test to see have my platelets crashed. Yep, it crashed again. Okay, go back up. For withdrawal, normal, like people normally have normal blood tests. Like everything looks pretty good in your blood, except possible glucocorticoid induced hyperglycemia. Basically, you can have high blood sugar because this is a glucocorticoid we're talking about. Gluco meaning glucose, meaning this is what the drug does to everyone. It causes high blood sugars in general. Not necessarily like high off the charts for everyone, but like that's how it works. One of the things it does is regulate glucose. And so it's causing higher glucose in virtually everyone. So, what about adrenal insufficiency? What blood tests would they see in the hospital? Low blood glucose, hypoglycemia, low sodium, hyponatremia. Essentially, you don't have enough of that cortisol to keep your blood sugars high. And so it's dropping. And you don't have enough to maintain your blood pressure. And so your sodium's dropping. Everything is crashing. And that leads to adrenal crisis. When you can't have a high enough blood pressure, you can't have a high enough blood sugar, you go into a crisis, your organs start failing, and some people die. That's what we want to avoid. Okay. What about the HPA axis? Those two parts of your brain and above your kidney. Do we need a test for that? If it's your disease that's flaring, there's no point in testing for it because it's your disease that's flaring, right? If it's glucocorticoid withdrawal syndrome, they say testing is not recommended. If tested, ACTH and cortisol are usually undetectable. So those hormones that your brain is supposed to be sending to build cortisol, they're not being sent because you're taking the prednisone at high enough of a dose that it's not happening. So there's no point in testing. Basically, another way of saying this is everyone who's taking prednisone 15 and above essentially has clinical, like the test will show adrenal insufficiency. There's no point in testing for it. You have the inability to make adrenal hormones yourself, whether you have withdrawals or adrenal insufficiency, definitively. It's kind of like this is the problem, but these people actually have the blood test showing it, even though it's not a problem. A little bit confusing, but we're getting to a better answer. Okay, so if you have adrenal insufficiency at the beginning of tapering, this is what it will show: low ACTH, that hormone right here, and low cortisol. Later in recovery, normal to elevated ACTH and low cortisol. So it's saying that this part of your messages start being sent as time goes on, as you're recovering, but for some reason, you're still not making enough cortisol. Okay, so the problem is at the adrenal cortex itself. So that is the adrenal insufficiency definition, is when you can't make cortisol. Okay. And then what are your risks for adrenal crisis? It's not applicable for your disease flaring. And it is incredibly unlikely because if you have glucocorticoid withdrawal, according to their definition, you're taking more than your body would need to survive a disaster situation. And they say unlikely if glucocorticoids are administered, as patients with glucocorticoid withdrawal syndrome also have adrenal insufficiency. How very confusing. And then what is the risk of adrenal crisis for adrenal insufficiency? They say yes, if not optimally treated with glucocorticoid therapy. So now that we have the risks of what it could be, like, is it your disease flaring? Is it withdrawal? Or is it adrenal insufficiency? And where is there a point in testing? What test should we look for? So essentially, you've gotten down below that 15 milligrams. You're getting close to the physiologic dose, 4 to 6 milligrams. When can you start testing to see if you have adrenal insufficiency or if it's probably adrenal insufficiency or your risk? Is there a test? Is there a point in testing? And they actually have a test. I'm so excited because everything I've read before now was like, there's no point in testing if you're still on prednisone. Because, like we just said, everyone has adrenal insufficiency according to the test at certain doses. Now, if you get to somewhere in the range of prednisone 4 to 6 milligrams, that is when we can finally start testing. Okay, so step one, we have to rule out your disease flaring, okay? We have to make sure that your disease is under control, that your taper has succeeded. I'm going to get into what taper they recommend, but your taper has succeeded to this point, to 4 to 6 milligrams, and your disease is still under control. If it's not under control, you need to go back up to where your disease was under control, get on another medication, work with your doctor. But now that we know your disease is under control, this is when we're going to talk about testing because that's no longer a concern, right? And then let me pull up their cute chart. Make sure I don't miss any really important details they share. Okay, here's the chart. So step one, make sure that you actually no longer need the prednisone for your disease, that we are no longer in a therapeutic taper. We are now stuck in an endocrine taper, what I used to call the taper trap. And I think I still like that better than endocrine taper. That's kind of a really big term. The taper trap, where you have a hard time tapering without having your withdrawal symptoms. Okay. So now they say gradually taper. At that point, you have two options. You can just continue tapering, or if you're curious, you can get tested. If you want to get tested, they recommend everybody an early morning cortisol test. That's what they recommend. So, what is an early morning cortisol? What does that mean? There used to be these really fancy, expensive tests, the ACTH stim test or the concentropin stimulation test or the insulin tolerance test, and all of these fancy, expensive, painful ways of testing the HPA axis that kind of like went around but didn't ever quite get to the cortisol itself because it was thought that there's no point in testing cortisol. And knowing that ACTH, that hormone that connects, it's sending the signal to make cortisol, if you want to get that as an infusion, it used to cost like $1,000 a dose 15 or 20 years ago. And then some private equity company bought it up and hijacked the price. And now it's like $50,000 a dose. And so to do a test for this would cost like $50,000. And it doesn't even actually get the response we want. The actual, like it's like measuring blood pressure to find out how your heart is. Like it kind of tells us how your heart is, but it's not actually measuring your heart, right? It's measuring how much pressure there is on your arm. So it's an indirect measurement. So now they're like, actually, the amount of research has been done. We can test early morning cortisol. And so early morning, they're saying between 8 and 9 a.m. And that is because cortisol is normally secreted by your body in a rhythm. It starts getting higher as the sun is starting to rise and peaks when the sun is rising. And then it slowly goes down throughout the day. And at bedtime, it's really close to nothing. And then it starts over again, peaking when you need to wake up and then going down. And so testing right then when you'd be waking up is the most accurate test. But most labs aren't open at like the crack of when you wake up. And also you have to drive there or get there somehow. And so hopefully you can get there by 8 o'clock and get that test between 8 and 9 in the morning. And it's a super cheap test. Any doctor can prescribe it. It's like 10 or 20 bucks. It's just, can you get your doctor to prescribe it, right? If you don't like being pricked and you have a hard time transportation, there's also a saliva version they said is an option. Let's see what they said. A promising alternative is waking salivary cortisone or cortisol. This non-invasive and practical ambulatory test holds the promise of replacing in-hospital assessments, but is not currently widely available. Well, that's not true. If you're watching this, I have it widely available. I have the ability to order tests for you. You can either get that blood test, take it to a lab, and then show the results to your doctor, or you can order that saliva test. And they're on my website. If you are interested, I should have like created a landing page or something for you to share your interest. You should send me a DM if you're on social, or you should send me an email. Here, I'm going to put it in the chat. Send me an email to Megan@prednisonepharmacist.com. Send me an email and I will send you the link to get that blood test because it's super easy. One bottle, like one little vial, it's like $10 a test. So I can send you how to buy it. Kathleen says, you're right. I noticed increased fatigue discomfort of PMR when tapered from 20 to 17 and a half. I haven't actually talked about tapering yet. Okay. And then Janet says, I just tapered from 12 and a half milligrams after 39 days at 15. I do take methotrexate. So that's fantastic. You have methotrexate to help you. So how do they recommend tapering? Now that you know that once you get to 4 to 6 milligrams, you can test to see if you're at risk for adrenal insufficiency. Oh, yeah. And the numbers are if you're above 300, you're likely not going to have adrenal insufficiency. If you're below 150, yikes, you might have adrenal insufficiency or you might be testing too soon and just continue taking prednisone and retest in several months. Okay. So let's talk about their taper plan right here. Basically, they're saying that when you are at a really high dose, you can make bigger jumps in shorter time periods. And then as you're getting closer to that physiologic dose of 4 to 6 milligrams, it's often necessary to be slower and make smaller changes. The way I used to describe it is you need to stay in the 10 to 20% drop. And so 20% of 60 milligrams is 12 milligrams, right? So you can drop a lot. Whereas 20% of 10 is 2 milligrams. So the drops can be drastic when you're at really high doses, but they need to be more refined as you're getting lower if you're struggling. Going back to if you're only taking prednisone for 3 to 4 weeks, you don't need a taper according to this. But if you're struggling with the taper, you're having that withdrawal symptom, you are having that miserable experience, then this is what they recommend as a possible way to taper. And I also will include a link to my taper chart. Maybe that's the best way. Get my taper chart. It includes their strategy. Actually, I already had it in here. But if you click that link or scan that QR code, someone just did, then it will give you a printable version of this that you can follow like each day. So this is what they say. If you're above 40 milligrams, you can drop by 5 to 10 milligrams at a time every week. So that's pretty good. That's pretty fast, pretty rapid. And then between 20 to 40 milligrams, drop by 5 milligrams at a time every week. Then between 10 and 20 milligrams, we're getting closer, right? You drop by 2.5 milligrams. So you go from 20 to 17.5 to 15 to 12.5 to 10. And you can do that every 1 to 4 weeks. Everybody's different. You got to listen. If you're feeling those withdrawal symptoms come back, slow it down. Slow it down. Go back up to whatever dose you weren't experiencing that. Okay. Someone else just scan that QR code. Okay. Then once you're below 10 milligrams, between 5 and 10 milligrams, you drop by 1 milligram at a time. That means you need a prescription for 1 milligram tablets. They make them in America, maybe not in other countries, but in America, you can get 1 milligram tablets and you can do that drop every 1 to 4 weeks. So you can drop by 10 to 9 to 8 to 7 to 6 to 5. Then, once you get to 5 milligrams, this is what they say. In the absence of clinical symptoms or negative testing for adrenal insufficiency, continue 1 milligram decrease. And if you're struggling to get even more refined than that, you could switch to hydrocortisone, and that can make an even more refined drop. Or I have a lot of other strategies on my taper chart, like every other day. Like one day you take 10, the next day you take 9, 10, 9, 10, 9 to slowly drop doses, right? Okay. And then they say for those drops, when we get to 5 milligrams, it's every 4 weeks. So that is a really super slow taper. So if you were to follow that to the max, this is more than a year-long taper. So if you want access to how to do that, just click this link and get my free printable taper chart. It's exactly what you need to know how to taper prednisone. And then I hope I have answered all of the questions that you had in the chat throughout this conversation, because I feel like they were very similar in that I'm feeling this horrific, miserable feeling. What is it? Is there anything I can do to test for it? How do I taper? And this is how you can taper. And once you download this, I'll send you an email. And if you want my link to order your own early morning cortisol test, just respond to the email that I'll be sending you. And I'll send you the link to that test that's on my website. And that'll be really easy for you. In the future, if you're watching this in the future, there will be a kit. And it's called the Cortisol Clarity Kit. And it has that early morning cortisol test that you can easily order, take it to your doctor, make sure everything is safe and helpful for you. So just click that link and you can get a free printable taper chart. Reply to the email, say, hey, I want your cortisol clarity kit, and I will send it to you. Signing off as Dr. Megan, your prednisone